performed a series of 842 grafts, and was really, in a way, the founder of eye banking, since he was the first surgeon to use cadaver corneas. Here you can see, run the video please, in this film, the Filatov procedure, in which a metal blade is passed across the anterior chamber to protect the intraocular contents from the trephine. This film is from the 1940s. And this is what was done before we had viscoelastics. So instead of Healon, one passed a metal blade across the anterior chamber, and then during the excision of the cornea, the intraocular contents were protected. Of course, the great innovator was Ramon Castroviejo, who came from Spain to the United States and was really the father of modern keratoplasty for many, many reasons, largely because he miniaturized ophthalmic instrumentation. He was the proponent of the square graft, which made sense in 1929 when he first devised this, because at that time there were no direct appositional sutures, no microscopes, and so the square graft provided stability to the wound under overlay sutures. If you can run the film, please. Here you can see in this video from the 1940s a square graft which has been fashioned using the Castroviejo technique. You'll notice that the surgeon picks up the graft from the endothelial side, suggesting that they really did not understand at all the role of the corneal endothelium. Here you can see the recipient. You'll notice the sutures are lying on the surface of the eye. These are the overlay sutures, which will be pulled into place once the corneal graft is excised. The square graft was quite functional. Several of these are still in my practice today and have had fairly good refractive results. You can see here the series by James Acquavella, and many of these grafts were functionally clear and had good vision. One of the great advances in keratoplasty was eye banking. In 1940, Art Townley Payton founded the first eye bank in New York City, and that, of course, has grown into the largest eye banking association in the world. We live now in the age of lamellar keratoplasty. So we've come full circle from lamellar keratoplasty in the 1820s back to lamellar keratoplasty in the 2000s. Laser-enabled keratoplasty is something which Enrique just covered, so I will just mention this very briefly. This, of course, provides precise tissue alignment, custom-shaped incisions, predictable and stable alignment, the reduced necessity for excessive suture tension, early suture removal, and greater wound strength and stability. And we've all seen the variety of shapes which are available in the femtosecond laser technique. And since Enrique showed us such beautiful films, I'm going to skip this one. But to say that there are actually very few good papers that are currently published on endothelia, on femtosecond laser keratoplasty, largely because of the very significant expense in putting this effort together. Perhaps the best of these is by Luciani Barbosa, who was supposed to be here but could not be at this meeting. She had a series of 60 patients with keratoconus who she evaluated prospectively and compared with standard penetrating keratoplasty. And as you will see, the refractive outcomes are similar with standard penetrating keratoplasty and femtosecond laser keratoplasty. The pachymetry and specular microscopy is similar, but what is different is that these patients see better from the beginning, and our own experience at Davis has been that. Finally, to conclude, we are entering the age of the bioconstructed cornea. Several years ago, May Griffith described a collagen-constructed cornea, which was chemically cross-linked, and there's great interest in this. Here you can see the first of these, which have been transplanted in Sweden by Per Fagerholm. You'll also notice, interestingly, that there are overlay sutures that are used in this, just as were used in the 1800s. And this is a bioconstructed cornea, which we cut in our laboratory with a femtosecond laser in a sombrero fashion, and we are currently implanting these in dogs. So in conclusion, the evolution of keratoplasty has undergone a kind of circular history. We began with lamellar grafts in 1864, moved to penetrating keratoplasty in the early 1900s. We returned to lamellar keratoplasty in the 1990s, and now standard keratoplasty is DSEK, DALK, implants, collagen cross-linking, and bioconstructs. The pioneers of keratoplasty were clinician scientists who used the best methodology available and a contemporary understanding of physiology. But these are the underpinnings of modern corneal surgery. Surgical procedures involved with increased understanding of corneal physiology, improved technology and instrumentation, monitoring of outcomes, and careful prospective evaluation. Thank you very much. Okay, I'm giving the next talk as well. So, could we have the talk on high-risk keratoplasty, please? So this is a little bit more clinically oriented, and what I'd like to do is share with you some thoughts on corneal transplants that are done in high-risk situations. And this is important both for the corneal surgeon and for the eye bank to understand. The high-risk graft is high risk for a number of reasons. Either high risk for immune rejection, high risk because of chronic surface disease in the recipient, high risk for concomitant glaucoma, or high risk for recurrence of the primary disease. Let's talk first about immune rejection. Factors that increase immune rejection in the graft include more than one quadrant of vascularization preoperatively, the size of the graft that's placed, the age of the recipient, and whether or not this is a primary or repeat transplant. Risk factors for graft rejection postoperatively include the formation of peripheral anterior synechia, manipulation of the graft, chronic inflammation, or recurrent disease. We all know that in routine grafts, there is about a 20 to 25% incidence of graft reaction, which we can usually turn around. In high-risk grafts, graft reaction is up to 50 or 60% in incidence. There are, as you know, 4 types of graft reaction. Epithelial rejection. Here you can see a sequence in the same graft over a 4-day period of an epithelial rejection. Inside the fluorescein line is the donor epithelium. Outside the fluorescein line is the recipient epithelium, which gradually replaces the donor epithelium. This usually occurs in the first 13 months after keratoplasty and is generally benign. Another form of graft reaction are subepithelial infiltrates. These look exactly like those after viral conjunctivitis, but they're only in the graft and are not associated with other surface inflammation. The one, of course, that we are most concerned about is endothelial rejection, which destroys the fluid-controlling endothelial cells. For mild graft reactions, we treat these with, in other words, epithelial rejection and subepithelial infiltrates with topical corticosteroids. For more moderate reactions with endothelial rejection and graft edema, we use topical, sometimes oral, and sometimes intravenous or subconjunctival steroids. And likewise for severe graft rejections, generally intravenous and oral steroids, in addition to frequent topical steroids. In the high-risk patient, we need to be prepared for graft rejection from the beginning. So there are two possibilities for this. One is to prevent host sensitization, and the second is to suppress the host response. Prevention of host sensitization has eluded us till this time, although many people have tried to mask antigens. The collaborative corneal transplant study, which was done about a decade ago, looked at antigen matching, HLA, AB, DR, and ABO compatibility. And the conclusion of that study was that HLA matching did not really reduce likelihood of graft failure at 3 years, and that donor-recipient cross-matching does not increase the risk of graft failure. ABO matching was thought to be of possible value, but that's now been disproved by the cornea donor study. So what are the options? Many surgeons remove the corneal epithelium. This is not commonly done anymore, but it is a way of removing the most antigenic portion of the cornea. Second is to pre-treat the donor cornea with hyperbaric oxygen, virtually not done at this time. And then immunosuppressive therapy, which is the mainstay of managing high-risk keratoplasty. And that includes corticosteroids, cyclosporin, tacrolimus, and mycophenolate. We all know about steroids, so I'll pass on steroids, but say a word or two about cyclosporin. Cyclosporin, as you know, is a cyclic polypeptide which inhibits the transcription of IL-2 and is a potent inhibitor of cell-mediated immunity. Studies of cyclosporin in keratoplasty in the early part of the decade showed that cyclosporin was definitely effective when compared with control groups in decreasing overall rejection rates. However, oral cyclosporin has significant systemic side effects, as you see. Tacrolimus, or FK506, is a macrolide antibiotic isolated from streptomyces, and it inhibits T-cell receptor-mediated transcription of IL-2. It's very commonly used in renal and liver transplantation, and its limitation in corneal transplantation is that it has, again, significant systemic side effects. And finally, mycophenolate, or Cellcept, has been used, at least in comparison with cyclosporin, in a prospective study of 25 grafts and showed very comparable, if not better, results in preventing graft rejection in high-risk keratoplasty as compared with the cyclosporin patients. There are, of course, new immunosuppressive agents on the market, including basiliximab, which is a monoclonal antibody, which is now being looked at. And many people, I presume people in this audience, have used bevacizumab or Avastin to inhibit corneal vascularization in the high-risk graft. Bevacizumab is administered subconjunctivally, produces an immediate regression of vision of vessels. But unfortunately, the vessels recur, and so it can be used as an adjunct to low-dose topical therapy with steroids. But in and of itself, it is not an acceptable form of management of high-risk graft. There is a wonderful review of all of the anti-VEGF therapies in the anterior segment by Hosseini et al. In the 2000 volume of Cornea. So high-risk keratoplasty can also occur from ocular surface disease, either from scarring, vascularization, rejection, infection. It can lead to those things. High-risk patients for graft failure include chemical and thermal burns, Stevens-Johnson syndrome patients, cicatricial pemphigoid, or patients with neurotrophic disease. For all of these patients, as you'll hear again and again during this meeting, it's important to stabilize the ocular surface in these high-risk patients using non-preserved artificial tears, liberal use of tarsorrhaphy, punctal occlusion, suppression of inflammation, and the use of stem cell transplants in the form of conjunctival limbal autografts and keratolimbal allografts. Glaucoma creates a high-risk patient. So the patient who goes into keratoplasty with glaucoma needs to be consulted prior to the surgery. And finally, those patients who are grafted for diseases which can recur, such as herpes simplex, one needs to manage these patients with antiherpetic prophylaxis, often for a lifetime after penetrating keratoplasty. So in conclusion, the high-risk graft is managed by careful planning, accurate determination of what the risk factors are, good pre-surgical management, prophylaxis, treatment with steroids, management with tarsorrhaphy, etc. Optimizing the ocular surface, prophylactic medications, and management of the vasculature, glaucoma assessment and treatment. And then all of these patients require meticulous post-surgical observation with chronic immunosuppression, antiviral prophylaxis in the case of herpes, close monitoring of intraocular pressure. Thank you very much.
¿Alguien del público tiene alguna pregunta para el doctor Manis? I have a question, doctor. I have a few patients in my own practice and who has transplant for keratoconus in both eyes. But one of the eyes have a rejection and the fellow eye doesn't have. I even don't put any drops of corticoids, but the fellow eye I have to put every time. I don't know if that happened with you.
It's a very interesting question. Yeah, it's actually very common to see that in patients with bilateral transplants that one of the two eyes becomes the more problematic. The literature would suggest that there is a higher incidence of rejection in the second eye. The idea presumably being that the first eye is the sensitizing transplant, and that when you place the antigenic load in for the second transplant, the body is prepared to provide an immune reaction. So more commonly when we see unilateral immune response, it's in the second graft rather than the first graft. But I tell all of my patients who have bilateral surgery, particularly the keratoconus patients, because they're young and they have healthy immune systems, that not only is there a higher risk of graft rejection in the eye we're about to do, but there's also a higher risk of rejection in the first eye. And in the first year after the second graft, I treat the first graft as well with steroids.
Thank you, doctor.
Perdón, cuando hacéis una trepanación vertical con el láser de femtosegundos en el donante, ¿qué presión usáis en cámara anterior? Porque yo siempre tengo dudas si es mejor usar una presión muy alta para coger una correcta aplanación. No sé si es mejor usar una presión muy alta.
Yo creo que depende mucho del femtosegundo que utilices. Los femtosegundos que aplanan requieren presiones altas. De otra forma,
¿Altas como cuánto?
60. Y probablemente eso dañe el endotelio. Los femtosegundos, los videos que mostré, por ejemplo, del Visumax, esos generan un poco vacío, tienen una superficie curva, entonces casi no aplanan y no dependen de la presión que tienen.